The title of my talk is Exploring Whether Systemic Therapy for Psoriasis Improves Heart Disease in Clinical Trials. These are my disclosures. And I'm going to give three major elements of this talk, just to show a little bit of the evidence linking psoriasis to cardiovascular events, so we know the clinical significance, look at different clinical trial approaches used to date to look at how immune-targeted therapies impact cardiovascular disease, and discuss where I think our future opportunities are. So just briefly, this is a multifactorial problem that we are dealing with our patients. Patients have environmental risk factors that make them prone to psoriasis, genetic risk factors, the disease itself, as Michael sort of laid out, the therapies we use, and then the psychosocial burden. All of these things confer some degree of cardiovascular risk. I'll just point out one recent study that came out in Nature Communications using something called Mendelian randomization design. It's essentially a genetic study where they found the genetics of coronary artery disease were causally related to developing psoriasis over time. And so that just reminds us that these relationships may go back and forth. Psoriasis possibly could cause atherosclerotic disease and cardiovascular events, but also people have underlying cardiovascular disease or atherosclerotic disease that may also be a trigger for psoriasis as well, given that that's an inflammatory condition of itself. Now, there's real clinical significance to this problem. People with moderate severe psoriasis die about 5 years younger than they should, based on their risk factors for mortality. The 10-year risk of having a cardiovascular event attributable to psoriasis is about 6%. That's very similar to, say, diabetes. And a person who has moderate severe psoriasis is about 30 times more likely to experience a major cardiovascular event related to psoriasis than they are to develop a melanoma. And as dermatologists, we all do full skin checks on our patients. We know how important melanoma is, and this sort of puts it in context here. So if we're able to solve the cardiovascular risk problem in our people with psoriasis, we will do a major benefit for them, just the way we do when we screen for melanomas. And guidelines have come out to really emphasize these points. This is from the American College of Cardiology, American Heart Association, and psoriasis is now viewed as a cardiovascular risk enhancer, along with diseases like rheumatoid arthritis or HIV. And as I think Michael's talk showed earlier, many of the other comorbidities our patients have, including metabolic syndrome, or inflammatory arthritis, psoriatic arthritis, are also very prevalent in our patients. So our patients can have multiple cardiovascular risk enhancers. And according to these guidelines, they should be considered for statins earlier along their journey in cardiovascular risk management. And then finally, another paper just came out just emphasizing the breadth of data, a meta-analysis, 31 studies, 665,000 patients with psoriasis, 17 million controls. I can't think of any other disease out there that's been this intensively studied for psoriasis and cardiovascular risk. Even RA doesn't have this much data behind it at this point. All right, but this is really the key question. In 2006, when I was sort of involved in this area, all people told me, like, why study psoriasis? It's just a skin disease, doesn't harm anyone, it's just cosmetic. In Oregon, the insurance called Medicaid refused to treat psoriasis. I think it was elective to treat. It didn't require government funding to treat it. Incredible how far we've come based on the observational data, the genetic data, and the data that Mike just showed you in terms of our understanding of these relationships. But the problem is that the immune system can cause paradoxical effects. TNF inhibitors can be very anti-inflammatory in the skin, the joints, but they can be pro-inflammatory in the central nervous system, and they can even cause psoriasis-like lesions. IL-17 inhibitors are very anti-inflammatory in the skin and joints as well, possibly also for hidradenitis, but can be pro-inflammatory in the gut. And then tofacitinib, well, we know it lowers hsCRP, but it seems to have issues with thrombosis and all-cause mortality. And again, just to emphasize this point, a lot of the basic work being done to look at IL-17 and cardiovascular disease, IL-17 seems to have both pro and anti-atherogenic effects in the various models that are looked at. So, there's basically two broad approaches to trying to tackle this question about what do our therapies do to cardiovascular disease. One is to do biomarker studies, and the second approach is to do event-driven studies. And these studies can either be observational in nature or randomized controlled trials in nature. I would argue that the best data ultimately comes from randomized placebo-controlled trials or active comparator trials of events, because patients care most about events when it comes down to, as opposed to biomarkers. So, for the last sort of 10 years or so, Nehal Mehta and I have been working on this sort of model of 18-FG PET-CT as a measure of systemic inflammation and vascular inflammation in people with psoriatic disease. And the reason why we thought this was a very good model to study is because it's felt that radiolabeled glucose uptake is a marker of CD68 positive macrophages and fatty plaques, which is a driver of atherosclerosis. These imaging techniques are predictive of future cardiovascular events. And we've shown that vascular inflammation is increased in people with psoriasis compared to people without psoriasis, and that the worse their skin disease is, the worse their aortic vascular inflammation is. And then finally, other trials have shown that if people go on statins, medications known to prevent cardiovascular disease, that their aortic vascular inflammation will reduce within 4 to 12 weeks. So this is a nice imaging biomarker because it's highly sensitive and it changes rapidly, within a couple of weeks period of time. So that's very advantageous. And psoriasis is a particularly interesting model because we could give people placebo for a short period of time, 12, 16 weeks, whereas you cannot give placebo. And there's my dog who's agreeing with this talk right now. So we could give placebo. Let me pause for 1 second. I'm very sorry. I'll let the dog out. Give me 1 second. Out you go, boy. Out you go.
I think he's interested in the topic, Joel.
I know. Well, he clearly disagrees with some of my hypotheses. I apologize for that. Okay, so basically, it's a useful marker because it responds quickly. And with psoriasis, we can give people placebo. You can't really give people placebo, say, with rheumatoid arthritis or other inflammatory diseases. So it's a nice experimental model. And we've conducted 4 of these trials. 3 were randomized placebo-controlled. 1 was adalimumab versus phototherapy versus placebo. That was sponsored by the NIH. 1 was an IL-17 inhibitor, secukinumab versus placebo. That was sponsored by Novartis. And then 1 was ustekinumab versus placebo. That was sponsored by Janssen. All of these are investigator-initiated studies, all studies that we did and analyzed and reported. And finally, most recently, we report on the VIPA study. It's an open-label study of apremilast. And this is sort of a summary of our work and other work in the literature, looking at randomized placebo-controlled studies of cardiovascular biomarkers in people with psoriatic disease. And so there's been 2 studies of adalimumab, 1 by Robert Bissonnette in Canada and 1 by us. And then also our study of ustekinumab, secukinumab, and another one of secukinumab that was looking at flow-mediated dilation. And the summary of what we found in this meta-analysis that was published in the JID about a year ago is that the strongest reduction in blood-based cardiometabolic biomarker risk factors was observed with adalimumab, which improves CRP, TNF, and IL-6A, and a biomarker called glyc-A. IL-6 is interesting because it's causally related to cardiovascular disease. We know that from a variety of lines of work. So when you lower IL-6, it gives you a lot of confidence that you're likely to lower cardiovascular events. Interestingly, phototherapy lowered CRP and also lowered IL-6 as well. And only phototherapy in this model improved lipids and increased HDL particle size. Ustekinumab, which blocks IL-12 and 23, improved aortic vascular inflammation at week 12, but that was transient. When we followed people out for a full year, it went back to their baseline. And then none of the therapies we use seem to improve insulin resistance. And so that gives you some insight to where things are with these biomarker-based studies. All right, so briefly about apremilast. This also had a neutral impact on aortic vascular inflammation. Although interestingly, people who had higher levels of aortic vascular inflammation at baseline had improvements in their VI at week 16. But what's most interesting about this study is that subcutaneous and visceral fat reduced by 5 to 6% in apremilast patients, and that was maintained for 52 weeks. That's kind of an interesting observation from this study. And we know metabolic problems are such an issue in patients with psoriatic disease. There are also a number of improvements in a variety of different metabolic biomarkers as well, but again, this is not placebo-controlled. And part of the reason why I argue that placebo control is so important is you can see this work that Nehal had led, I was a collaborator on, showing that anti-TNF therapy in people with psoriasis is strongly associated with a reduction in the aortic vascular inflammation. So that's observational data, borderline p-value, but still significant. But when we did it in clinical trials, at least 2 trials, proving no benefit of adalimumab on aortic vascular inflammation. So placebo control is often very important in these highly sensitive markers. A place where the work may go next is Nehal's been developing the technique of coronary computer tomography angiography for studying plaque disease, in this case, atherosclerotic plaque. And what he's able to show is that psoriasis is associated with an increase in non-calcified plaque burden and high-risk features that seems to improve with the year of biologic therapy. And again, that's work that we want to now look at with RCTs. The other issue about biomarker studies is that they're often not accurate in terms of predicting the true outcome of events. This is a review in the cardiovascular literature, roughly a 55% positive predictive value of when you do a clinical trial of a biomarker and then following it up with the RCT of actual events. Do you actually find confirmation of improvement in events? So you always have to do the event-driven study after the biomarker study. So there have been 3 major clinical trials now looking at immune-targeted therapies and cardiovascular events in the cardiovascular field. So here the model is looking at people with very high cardiovascular risk because they have established cardiovascular disease, have had a prior MI. The canakinumab study, it's a biologic blocking interleukin-1 beta, and that did reduce cardiovascular events in these patients, but had an increased risk of infection and mortality due to infection. And so that made it not a very viable strategy for secondary prevention. But you also notice the sample size, 10,000 patients, average age 61. Methotrexate, there's a study based on observational data and biomarker data, which thought would be effective in lowering cardiovascular risk. This had no benefit whatsoever in cardiovascular risk in people who had a prior MI or multivessel coronary disease and diabetes. Interestingly, there was a small increased risk of non-BCC skin cancer and an increased risk of non-serious infections, but the drug was actually pretty safe in a large population of people, nearly 5,000 people, who were about 66 with coronary disease and diabetes. So that's reassuring for our use of it. And finally, Colcott, a colchicine. There's a study of people who had a recent MI, and here they had a reduction in having another MI in the future if they got colchicine compared to placebo. There was an increased risk of pneumonia as a serious adverse event. And the colchicine findings have been replicated in other clinical trials. So some preventative cardiologists are now starting to use it in patients. More recently now, coming back into our field of inflammatory diseases, there was the oral surveillance study published in the New England Journal of Medicine. This was a randomized open-labeled study of TNF inhibitors versus tofacitinib in people with rheumatoid arthritis. They had to be 50 or older and have at least one cardiovascular risk factor. And what this study essentially showed or conclude is that TNF inhibitors, or I should say tofacitinib, is not non-inferior to TNF inhibitors when it comes to cardiovascular events. Stated another way, you seem to get better cardiovascular event outcome rates if you get a TNF compared to getting a JAK inhibitor. And so that raises the issue for us to keep in mind that we have all these different targets in psoriasis to use, and which target we use may have different impacts on cardiovascular events. We still need to tease that out. So in my last minute or so, I'll just say that I think we have 3 approaches going forward. One would be imaging coronary arteries, like I showed you earlier in the talk, the coronary angiography. The advantage here, that's the money. That's where we're trying to go to improve athero and cardiovascular and the coronary arteries themselves. The disadvantage is that it takes about 12 months to see changes here. You need sample sizes in the hundreds of people, and you probably need an active comparator. We can't give placebo to people with psoriasis for a year. Maybe doing these studies in people with cardiovascular events or people who have known coronary disease. This is relatively efficient because they have very high risk. So just like we studied methotrexate in people with coronary disease, we could study, an IL-17 inhibitor or IL-23 inhibitor or a TNF inhibitor in that population. The challenge with these event-driven studies, it takes a good, year to 5 years to accrue enough events. You need sample sizes in the thousands, and we won't be certain that this plays a role in psoriasis, because it's not going to be psoriasis patients. And then finally, studying for cardiovascular events in people with psoriasis. This would be really good for giving us insight to the natural history of disease. Following people in a randomized trial for years would be the definitive answer, and could be pragmatic. But similar to the last design, you're talking about thousands of patients, many years of follow-up, a lot of resources to do this kind of study. So I'll stop there and thank my lab and funding sources that helped me do all this research over the years, and delighted to stop there and hear the next series of talks.